Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Today I am speaking with Dr. Jared C. Rogers, Medical Director with Chestnut Family Health Center, and Dr. Todd Kettering with OSF Healthcare. Gentlemen, welcome.
Thanks for having us.
Yes, thanks so much for taking the time. Jared, where are you calling in from, if I may ask?
I'm from Bloomington, Illinois. I'm sitting right at my desk at my office, Chestnut Family Health Center right now.
Oh, of course, HQ. Todd?
Yeah, I'm also in Bloomington, but at the hospital here at OSF St. Joseph's Medical Center in Bloomington. So just a short drive from the medical center there on Chestnut Avenue.
Oh, okay, great. Just wanted to set the stage. So briefly, Jared, if you would, a little bit of background for our listeners, and then Todd, I'm going to ask you as well.
Sure. I was educated in Illinois, actually graduated from Southern Illinois University School of Medicine quite a few years ago. And so I have a fairly long professional history. I went into the Army right out of medical school, did my family medicine residency, and then spent 6 more years on active duty after the residency. And that included 4 years in Germany, where I served as combat medical detachment commander for those 4 years. Then I went into private practice in Washington State for 5 years, south of Seattle, and came back to Illinois, where I went into private practice in northern Illinois, a small town, Mendota, where we did everything, and was in that practice for 11 years before going into academia and taught in the family medicine residency in Peoria. At that time, I, for some reason, was identified as somebody that might be interested in being the medical director of Methodist Medical Center. And so I was asked, and I thought, well, I'll try and we'll see what that is. And I found that I liked it, and then started into somewhat of an administrative track, taking courses leading to a certified physician executive degree, and became chief medical officer for one of the OSF healthcare hospitals, which was then Presence Health in Urbana, Illinois. And after a couple of years of doing that, became the president over that hospital and the hospital in Danville, both run by Presence Health at that time, which OSF Healthcare bought out in 2018. And I continued as president until I retired in 2022. After 6 months retirement, I thought, well, I really don't necessarily like retirement altogether. So I was looking around, and a friend told me about this position, and I took a look at it and thought, that sounds interesting, particularly with starting the residency program, which I think we're going to talk about later.
Yes, indeed. That's amazing. From Illinois to Germany to Washington State to Peoria and now Bloomington. That's some journey. Todd, if you would, a little background for our listeners.
Yeah, sure. Well, I didn't travel quite as far as Jared did, but from Northeast Ohio is where I did my residency at Akron General Medical Center. I did everything there, loved every bit of teaching, so came straight out of residency into teaching, and took a great position here in Central Illinois at the other hospital in town. They had multiple residency programs that I was fortunate enough to not only shepherd through, but also start a new neurology program and some other exciting things in the business, which we call GME, or graduate medical education. That's where the training is after med school, and was able to come over and do this exciting project. Since my specialty was starting residencies, I was able to come start this family medicine residency from scratch, and just really delighted to now have 3 full classes of residents for the first time, and strong partnership with Chestnut Health Systems and their family health clinic over there. It's been really a fantastic partnership and exciting to be a part of that. I've always loved teaching. In fact, I used to pay my bills by teaching trombone back in college, high school and college. So taught private lessons, and it was actually probably one of the harder things to give up once I got into the workforce and more schooling. And I think in a similar fashion, rather than going into more administrative work, I think this opportunity was superior for me, just because I was able to continue in my teaching, and I just feel that's so rewarding to do. And so I'm really delighted to have this program right here in Bloomington.
As much as I really want to get into this conversation, I must ask you, trombone is a very specific thing. How did you get into trombone? There are
Well,
only
that's
a couple of trombonists that I can think. J.J. Johnson, right? Isn't he the classic
yeah,
jazz
right, sure.
trombonist?
Even Glenn Miller was, he played
Mhm.
trombone. So,
Ah,
but if you want to go way back, but it's interesting. The band director, I wanted to play trumpet, of course, and he comes and looks at me real close, and he says, "Yeah, your mouth is too big. You need to play trombone." It's really just
ah,
because they needed trombone players. And then, of course, he was the jazz director, and I really loved jazz band, and won the Stan Kenton Award my senior year, and actually played professionally in Canton, Ohio, for the John Trapani Big Band. So that was kind of cool. Other than I
wow.
had to join the union, and they took a lot of my money for the union dues because I didn't play that often because I was in college, right? But it was fun, and ultimately it's been a great journey with the trombone. I've really enjoyed it.
All right, fascinating. Had to ask. So, thank you, gentlemen. I really do appreciate that. So if you would describe the partnership between OSF Healthcare and Chestnut, how it came about, how it works, and the benefits to the communities you serve. Jared, if you can take that first.
Sure. I think that Todd can talk more to the mechanics of it and such. I can speak to the ambulatory experience that the residents in family medicine residencies need. And so
Mhm.
family medicine residency, besides having all the different hospital rotations for the specialty training, there's a longitudinal track through the 3 years where the residents need to be in an ambulatory center seeing patients, continuity patients. So they see this, a group of patients over and over again throughout their 3 years. And we serve as that site for the residents to do their ambulatory medicine experience. And so that's where Chestnut Family Medical Center comes in. That we have the patients, and we could certainly use the residents, and it worked out very well.
Excellent. Todd, from your perspective?
Yeah, I think Chestnut Health Systems has done such a great job with their FQHC here, with their family health center, serving certain populations, which was substance use disorder and mental health issues, and they've done such a great job with that. But they really are tasked as an FQHC, which is federally qualified health clinic, right? So that's a government funded enterprise, requires full spectrum healthcare. And the nice thing about a residency in partnership with that is that that's exactly what we do. We see kids, we give them immunizations, we see elderly folks, we see everyone in between, and we can take care of all those issues. And so it ends up being a great partnership because residencies in general see underserved and undercared for populations, and it's a natural fit to have a residency in a strong environment like the health center there at Chestnut Street. So it's really great.
Speaking of that, when we spoke to prepare for this, you used the term medical deserts, and many people tend to associate that with rural areas with people who have access to care, but it goes well beyond that. So, Todd, if you would expand on that.
Yeah, sure. The strategic location of the health center is in the west side of Bloomington. And if you're familiar with Bloomington, most of the activities on the east side. Yeah, I'm sitting here at the hospital, which was built, quite a while ago, but all around us is, the mall and lots of businesses and all the medical offices. And so, one of the challenges is for our population of patients that need to take a bus to see a specialist. It may take 3 bus transfers to get over across the street here from the hospital. And so to be able to provide, comprehensive, again, family medicine is really everything about a family. And that's what's been rewarding about my career, is taking care of multiple family members and multiple generations all at once, right? And so to have that all in one spot, and even provide some procedural components for minor things so patients don't have to do this travel to get the care that they need and get good care in an area that really just doesn't have any other facilities other than the hospital itself, which, we certainly know that these challenging populations utilize services such as the emergency room more often than the general population. And that's really just due to access issues. They're really just trying to, get their needs met. In fact, just today, I saw a patient who really woke up with really severe back pain, called our office. I was able to get in within an hour, and she said to me once I took care of her, she says, I was really thinking I was going to have to go to the ER and wait for 6 hours with my back in spasms. And I'm just so glad I was able to get in today. So, that's the kind of services that, and I'm sure she lived close by as well. I mean, that's really where the patients are, and they can come and get their needs met.
But that actually does speak to a bigger issue. And actually, when we spoke, you mentioned being approached by a former inmate needing care. And I asked how he and others like him, not just people coming out of the criminal justice system, but people generally, chiefly from underserved areas. How do they find out about your services? And you mentioned that you've been pushing your organization to do more marketing, billboards, but obviously resources are tight and probably getting tighter by the minute. So, how do you accomplish that on any kind of a regular basis other than maybe occasionally getting lucky?
Right. Well, I mean, I think, there is a marketing department. They do social media outreach, but case managers within certain organizations. I know that from working at the other hospital, the case managers, we actually had a social worker in the ED. I know that she's personally referred patients from the emergency room at the other hospital to Chestnut directly. And I'm sure, I don't know if they get kind of a discharge packet or something at the jail or prisons, but there may be a list of places to go, and they may call them and they may not get an answer, but at Chestnut, they're going to get an appointment and they're going to get seen by one of our residents or faculty in a very timely manner. In fact, that's one of the ways patients find where they're going to go. A lot of times that's why new patients will no-show in practices. They'll call and get 3 different appointments, and they'll just go to the first one that they get, and they don't even call the other ones to cancel. So, if you can be ahead of the game on access, right? Open access scheduling and some of the things that we've been doing at Chestnut. I think that's where you can find that you're going to open up the doors for populations of patients that need our help.
Right. Right. Jared, is this something that also falls on the Chestnut side of things? It seems like there's, to some extent, a bifurcation of services, but of course, there's coordination. On the one hand, um, OSF's providing the residents, and Chestnut is providing the patients and that infrastructure. To what extent does Chestnut do that kind of outreach to raise awareness that these services are available in and around the community?
Sure. Like Todd was saying, the social media presence is something that's really big. And Chestnut's been doing that now for a few years. The health center here has been in place for 12 or 13 years now. But just in the past few years, have we really gotten the word out and people know about us more? The other thing that we offer that many offices, health centers don't offer is we offer integrated care in terms of not only do we have family medicine, which is really quite a broad specialty, and we can take care of a lot of different things, all different age groups and such. But we also have on-site mental health providers, psychiatry, mental health nurse practitioners. They're not psychiatrists, but they really do a very good job with managing psychiatric medicines that a lot of our patients need. In addition to that, we have dental services, and that's been something now that we've had for about a year and a half, and it's been really well received. With so many of our patients suffer from dental disorders, and it's difficult for them to get in for those services elsewhere. And then, of course, we have the substance use disorder arm of Chestnut, where we, not only part of Chestnut, just, about a mile away, we have residential rehabilitation for substance use disorders, but we also have a physician who specializes in medication-assisted treatment or medication-assisted recovery for people who need specialty medications to, help them, come off of opioids or alcohol and things like that. And so we really offer this integrated care model that a lot of our patients need and really important in their lives.
There's this term, as you guys know, and some of our listeners know, whole person care. Is that one and the same, or is that something a little bit different from this idea of integrated care?
I think a lot of it is the same, and family medicine as well is, something that provides whole person care much more than any other specialty in medicine. So I think combining those with the other things that we offer, you really do start to approach that whole person care.
Todd, I'm curious. Technology changes, methodologies change, a lot of things change. Overseeing and coordinating the resident side of this, there have been any tectonic or significant changes in the last 2, 3, 5 years in the training process?
Well, I think we're still pretty traditional in medicine in general, so there's a lot of regimented things. But, I do see trends happening with AI, for example, where that's just too powerful of a tool to not be used. So, in fact, I had a patient the other day. He's, had obstructive sleep apnea. He doesn't like the machines. He wants to look at alternative options. I'm going over all the options. And then I stick it in AI. I said, you know what? I'm going to use AI. We'll see what it says, and it had everything I had, except it added one more thing. It added a new device that was just invented, and it was a thing he could practice with and get his muscles stronger and open his airways. And I was like, this is the future. I mean, we're going to be using this type of tool. Now, do I want my residents using AI to solve problems? No, we need them to learn how to solve problems, right? But it kind of reminds me of a time not too long ago when, we used to have our pockets full of papers, and that's how we had little books. We had little books with references. Well, then that kind of went away, and we had these little things that didn't look too much dissimilar from cell phones, and they were called Palm Pilots. And then we had docs on rounds, when you had the students and the residents, and they would say, "Oh, put that thing away. We don't want that here. You need to know this
Right.
stuff. You need to know this equation, the Hasselbalch equation. You need to know that." Well, you actually don't, because the machines do it now. And so eventually, a couple of years of that, right? Then we have to use these machines. Not only that, these little things started connecting to the internet. And then, then it would be like, well, Dr. Kettering, I got an article here on pulmonary embolus, and it shows that, we could do this, whatever. And so AI is just another tool that's going to be just like this. So we really have to embrace it. It's going to be transformative in many industries, if not all. So these are the tools. So that's where I see
Yeah.
probably the biggest changes that'll be coming in education. Will it replace doctors? Right? That's always the thing. Right? Will AI replace the doctor? Well, maybe it will, but it'll be a long time, believe me, because there's just going to have to be that human element to healing that really has nothing to do with giving the right information. It's really about the
Yeah.
relationship with patients and how we're going to get them better, right?
Yeah. Jared, any thoughts on that? And I just want to also introduce the idea of people using AI to self-diagnose, and that could lead to some problematic outcomes, I'm assuming. Jared, any thoughts on that?
It certainly can. I mean, Todd's right. The AI comes up with things that are just amazing, but there is always that you need some oversight. You need some wisdom in that AI, for many things. And sometimes one of the things you can't get with AI, and that is just a feeling that someone cares about you and really wants to help and really wants to make whatever's, ailing you better.
Yeah,
Yeah.
I mean, it's
No.
not dissimilar to Google years ago, when we just had search engines. And I had a patient come in and tell me one time, I don't even need you. I have Google, and I
Right.
said, well, that's fine if you want to think you're dying of cancer every time you search something,
Right.
like, I mean, I think, there needs to be some sort of guidance right around it, and it'll just transform the type of work we do. But, I think it's going to be really amazing. I mean, you see statistics like on agriculture. We live here in the heartland where it's harvest season right now, and it used to be like some staggering number of people, probably, like 40% of people that were employed 100 years ago were in agriculture, right? I mean, so that's just what it took to get it done, and we don't do that now, right? It's a small percentage of people that get the work done with their amazing machines, so we're going to have some cool tools to diagnose. I think you'll see emergence of more on-the-spot diagnostic tools that we'll be teaching about, like what they call point-of-care ultrasound, where a resident or provider will have an ultrasound to be able to diagnose more things on the spot. And honestly, labs are getting faster and faster. I mean, we can do point of care testing for several different things right in the office. And, this is really amazing to bring that to patients so they don't have to go to the lab, and we can get more real-time decision making right on what to do for their health.
Yeah, no, it's amazing. I did a podcast just last week, a guy who is the AI tech lead for a company. They're in India, and they do these ophthalmic early diagnostic tool, and it's just amazing the strides they've made. I also want to make a point that I think is kind of interesting. You mentioned people previously using Google to sort of self-diagnose, and Jared, you talk about that one thing that technology, particularly AI, can't do is project a kind of caring. But then the difference, in my view, and my experience and others, between, say, Google and AI, you've never asked Google and thanked Google for doing a search. But so many people, myself included, it's a weird reflex because you feel that there's a sentience on the other side of ChatGPT where you feel compelled to say please and to say thank you. And so it may give you an impression of caring, and that way may lead to some also problematic interactions when you're investing more into the AI tool than you really should. And any thoughts on that? I don't want to get too deep down this, but now that you brought it
Yeah,
up, I
well,
thought it worth
I mean,
talking
again,
about.
it'll be robots. I mean, I was a very much an Isaac Asimov enthusiast as a teenager, and read a lot of it, and he was really ahead of his time as far as both with AI and robotics. But again, I don't want to hijack the whole podcast, but yeah, so the robot will provide that. Right now, they can generate images of faces and right, but then it'll be an actual robot with expressions and speech that's pretty much normal. I mean, at some point, you're not even going to be able to discern, right, regular from not. I mean, I just saw another thing where some new AI, I think with Grok, is showing that it's creating entire movie scenes. I mean, these are things that used to take, hundreds of people to produce. It's all done. So yeah, I think the emotion part of that is going to be strong because they're going to make it so human like, right, that you're not going to be able to distinguish it. So that will be healing. Yeah, that will be healing. And so maybe they can optimize the healing, right? They can take the components, they can survey 10 people that are good at healing, and then they can put that into an algorithm, and then they get something even better.
Yeah, and it's all moving so fast.
That's right.
This conversation 3 months down the road would probably be a lot different, talking about the
Sure.
very same things. And last question, unless you guys want to bring up anything else on the pause, these conversations, given what's happening out there more broadly, the current climate, we tend to talk about the challenges. I'm going to flip the script a little bit and ask both of you, what are you most optimistic? We already touched on some of those things with some of the promise of AI. Jared, any thoughts on that?
Sure. I think one of the things that I'm really optimistic about is that even with the advent of AI, I think that, we all need each other. We have this need for human connection. And it may get to the point where you don't know if it's human or not. The AI is so good. But I think that, looking forward to, how long are we going to need physicians? We're going to need them for a long time because I think we all seek that human connection, and we can make that. And as family doctors, we're usually very good at that. And so I think that that's something to look forward to, that will continue.
Todd?
Yeah, I mean, we're always going to need physicians. The thing that sticks into my mind is, when I was in med school, there was a shortage of anesthesiologists at the time. And actually, there was shortage of medical students that would even choose anesthesia as a career because they're going to be replaced by nurse practitioners or the CRNAs that do that. And it's one of the top careers,
I
that
know.
medical students choose, right? And
I
so,
know.
but it was doomsday for anesthesia, and they were. I even got personally at home at my parents' house, they sent gold embossed brochures, come to our residency, to consider anesthesia, so I think when anybody's saying, oh, this is not going to go well, I kind of think, it's going to be fine. But, I think, the other thing that comes to mind is, people always, and I think this is something that's happened for a long time, but the newest generations, right? They just don't work as hard, and they just don't care as much as we did back in the day, right? And they don't do it, but they just do it different. And so AI is maybe one of these tools that's going to get them to do it different. And there's going to be another tool after that, and there's going to be another tool. And they do work hard and they study a lot, and there's a lot more to know. And I think there's always hope for me working with the next generation of physicians, knowing that, I can help guide them towards a better care and better understanding. And I like to bring in the history of things. I think a lot of times the history gets lost. Medicines that have been pulled off the market. I'll talk about this stuff, or vaccines. When we were talking about the COVID vaccine, okay, the COVID vaccine is still somewhat experimental, right? This mRNA technology. I don't think they've really still, to me, fully explained how that exactly works. I know they got through the trials. It was really rushed through trials, and there was obviously a different timeline to that type of technology. And I think they have extended it to other immunizations, but I think of like the rotavirus vaccine when that first came out. And the rotavirus, we used to admit kids. I used to go to the Children's Hospital in Akron, Ohio when I was there, both as a resident and as an attending. And the wards were full in the spring of kids, getting IV hydration because the rotavirus, severe gastroenteritis with nausea, vomiting, dehydration, the whole deal. And they came out with this vaccine, and they were given this vaccine, and it was just part of the schedule, and boom, it was shots. And then all of a sudden they're like, whoa, wait a minute. So there was this problem that came from that. And who would have anticipated that you'd get rectal intussusception or a prolapse, rectal prolapse which is when it comes out kind of inverted, right, from the shots. And they figured it out. It was the shots, and it wasn't a lot of kids, but it was enough that they said it's from this shot. And so what they do, they went back to the lab and they figured out, oh gosh, it needs to be done oral. And I remember talking about this at the time that the vaccine was coming out. And I said, so we might find that there's some bad side effect or something, and we'll have to just change how it's done. And I had the most learned group I'd ever have of med students and residents, and nobody had heard that story about, and that's just a few years ago, really, in my mind. So I think, again, AI might be able to bring in that, but, I think there's just the wisdom of your professors that you remember them telling stories and teaching you how to do things, and the apprenticeship model kind of done differently, right? So I think it just makes it and I want to inspire them to do better, right? I think there's just other elements of teaching that just won't be replaced by a machine, and it just makes it rewarding, and we don't have to worry about the next generation working hard because they're just going to work different.
Right. Well, thank you for taking us out on a optimistic note, both of you. I really do appreciate the time you spent with me today. Today, I spoke with Dr. Jared C. Rogers, Medical Director with Chestnut Family Health Center, and Dr. Todd Kettering with OSF Healthcare. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.